Thank you very much for the kind introduction. So the topic for this talk is hand pain. Is it always ischemia? So if you see patients like this with blue fingers in your dialysis unit, you would suspect ischemia of the distal extremity. If you see lesions like this, necrotic lesions, certainly that is a strong possibility. Having said that, the spectrum is pretty wide, and one should consider other differential diagnoses when patient complains of pain in the distal extremity. So here's a case to start us off. A 73-year-old gentleman with type 2 diabetes, hypertension, congestive heart failure, with an ejection fraction of about 25%. He's obese. He's been on hemodialysis for about 4 years, has had one failed right cephalic fistula, a radiocephalic fistula, and now has a functioning left brachiocephalic fistula. Complaints of numbness, cold fingers, which gets worse during dialysis. His dialysis prescription is about blood flow of 400 ml per minute. He gets 4 hours treatments with a 2K and a 2.5 calcium bath. His average interdialytic weight gain is about 2 to 2.5 kilograms. So does this patient have hand ischemia? That's the clinical question that is pretty frequently what we face. Now, a little bit on the pathophysiology of steel. So steel does not necessarily mean that the patient will have hand pains, and from literature we know that almost 70 to 80% of fistula, whether it is a distal fistula or a proximal fistula, can still have steel when investigated with any imaging technique. But besides the steel, so steel is certainly the biggest concern in these patients where you can have distal ischemia, and we really want to prevent any distal tissue loss. Besides steel, related to the fistula surgery itself, there are other possibilities that one needs to consider, and those include arterial stenosis, generalized arterial disease like calcification, compression neuropathy, and some of the other not very common conditions like reflex sympathetic dystrophy, ischemic monomelic neuropathy, and distal arthropathy. So in our patient, what are the possibilities? So being a diabetic patient, a diabetic peripheral arterial disease, or arterial stenosis, I mean, AV fistula is not just an anastomosis, it's a circuit that starts at the heart and ends at the heart, so you can still have a proximal arterial disease, and which can lead to ischemia in the distal extremity causing pain. Generalized arterial disease like calcification, again atherosclerosis, especially in the settings in India where the patient may be underdialyzed and patient may have extensive calcification. Again, underdialysis can lead to amyloidosis, beta-2 microglobulin deposition leading to carpal tunnel syndrome and hand pain, and then reflex sympathetic dystrophy or ischemic monomelic neuropathy. So let's go over some of these differential diagnoses in the next few slides. So arterial stenosis, the prevalence is known to be 30 to 50% in literature, and at least in this study, 10 patients had severe ischemia, which was related to a proximal arterial stenosis, which was easily treated with angioplasty, and post-angioplasty, with improved peripheral circulation, the symptoms subsided. Here's an example that I had in my practice where the patient had a brachiocephalic fistula. A patient had a brachiocephalic fistula, and if you look at the distal ulnar artery, there was pretty tight stenosis, which was the reason for peripheral hand pain, and post-angioplasty, the distal circulation improved with improvement in the symptoms. Again, there are various examples where there can be proximal stenosis. Here's a brachiocephalic fistula with a brachial artery anastomotic stenosis at the brachial arterial region, radiocephalic fistula with multiple stenosis in the radial artery that can cause distal ischemia and pain. Calcification, again, in diabetic patients, calcification is not uncommon, and here's an example where there's extensive, this is from literature, this is not from my practice, but extensive calcification can lead to distal ischemia and pain, hand pain. So rather than calling these patients as having Steele syndrome, one should use a more broader term that defines the pathophysiology behind hand pain, which is distal hypoperfusion ischemic syndrome, and that this definition or this terminology will encompass all the associated pathophysiological findings. So it includes arterial stenosis, calcifications, and calcifications related to diabetes or secondary hyperparathyroidism. How about reflex sympathetic dystrophy? This is also being called as complex regional pain syndrome. It's a fairly non-specific diagnosis. The diagnostic criteria are very diffuse pain, loss of hand function, and sympathetic dysfunction, so they're not very specific. And again, the risk factors that have been reported in literature include female gender, multiple access surgeries on the same arm, and again, presence of diabetes and peripheral arterial disease. So this is something that one should consider as a diagnosis of exclusion rather than a primary diagnosis. And again, in literature, this has been described to be present in 3 different stages, starting with stage 1, where there may be burning and throbbing pain with minimal edema, sensitivity to touch and cold. Stage 2, there is increased soft tissue and muscles edema, and stage 3, when there is difficulty in movement, hand movement, as well as development of contractures. And imaging techniques, especially MRI, has been shown to be somewhat beneficial in making this diagnosis. So coming to the crux of if it is truly Steele syndrome, and if we truly consider this as an ischemia related to the anastomosis or to the AV fistula that has been created, how do we handle that? So the reported incidence, again, in the literature is about 1 to 8%, and most of these patients will have hand pain either on or off dialysis. The fingers get cold, they get numb, and if treatment is not implemented in a timely manner, patient can also develop tissue necrosis. Again, there are 4 different stages that has been described. Stage 1, where the fingers or the hand can get pale blue or cyanotic. Stage 2, where the pain increases during exercise. Stage 3, when there is rest pain, and stage 4, then where there is tissue necrosis. The pathophysiology again here. So this is a brachiocephalic fistula. The brachial artery pumps into a low resistance cephalic vein, and so most of the blood gets stolen into the cephalic, into the AV fistula circuit rather than distally, leading to ischemia. So here the problem is mainly because of a larger anastomosis and high flow through the axis. How do we manage these patients? So in the early stages, about 80% of the patients, if the pain appears within 30 days of surgery, waiting may be the best strategy. If the symptoms do not progress, most of the times the symptoms will be self-limiting and patients may get by without any additional intervention. But if the pain or the symptoms persist beyond 30 days, the course is considered to be progressive, and generally some kind of intervention would be required. Now, again, there are several strategies that can be used to minimize the distal ischemia. It can be either a surgical intervention or an endovascular intervention. Surgical intervention essentially considering banding or plication of the anastomosis, and an interventional technique, which is the Miller procedure. As far as surgical banding is concerned, one can use plication or a graft constriction band around the anastomosis. The idea behind creating this constriction is to reduce the flow into the fistula across the anastomosis, so there is more blood flowing distally. The crux of this is the AV fistula generally would flow and maintain the flow and support dialysis if the access flow is maintained around 400 to 600 ml. In grafts, certainly one would need to maintain a blood flow of around 600 ml. Less than 600 ml of access blood flow can lead to increased incidence of thrombosis. There are several other revascularization procedures that have been described. Drill, which is the distal revascularization with interval ligation. Now here, the technique is not very used by the surgeons, primarily because a conduit is created from the brachial artery to the distal vessel, and the interval artery is ligated. So your flow to the distal extremity depends entirely on to this conduit graft. So if there is thrombosis of the graft, then you have further compromise on of the distal circulation. So this has really gone out of vogue. The preferred revascularization procedure that my surgeons have used, and having talked to the surgeons, several of the surgeons, that the preferred procedure is proximalization of the anastomosis. And here, creating a graft and creating the feed artery using a proximal anastomosis has been without further compromising any distal circulations. Even if this proximal graft anastomosis clots off, at the most you will lose the AV fistula, but not necessarily impact the distal circulation. Miller technique. Miller stands for a mouthful, minimally invasive, limited ligation endoluminal assisted revision technique. Blah. So I mean, this technique is used as an intervention endovascular procedure where a balloon, a small sized balloon, is introduced into the anastomosis, generally a 4 millimeter balloon, and externally a suture is ligated over the balloon, so you maintain at least a luminal size of 4 millimeters. This technique has been used, either of the techniques when used, the essential goal is to get the flow closer to 1 liter rather than maintaining it more than 1.5 or 2 liters. It also has an added advantage where reduction in the axis flow will also improve significantly the hemodynamics, cardiac output and the hemodynamics. So in nutshell, if a patient does have true hand ischemia, once the alternate etiology has been ruled out, performing a complete arteriogram would be absolutely essential. If an arterial stenosis is present, that needs to be treated. If the arterial stenosis is absent, so if the arterial stenosis is present, one can consider, if it is possible to do an angioplasty, one should consider an arterial angioplasty. If an arterial angioplasty is not possible, then a surgical intervention should be considered. So overall, rather than calling hand pain as Steele syndrome, one should call it as a distal hypoperfusion ischemic syndrome, which is mainly a vascular insufficiency, which could be either because of arterial stenosis, arterial calcification, or true Steele syndrome. I did not go into the details of ischemic monomelic neuropathy. That this is a fairly acute process where the hand pain starts within a very short period of creating a surgery after the anastomosis has been created, and this is believed to be secondary to ischemia of the nerves, and generally this has to be treated right away with axis ligation to preserve distal perfusion as well as function of the distal extremity. And then arthropathy is essentially if there are small joints of the hand that are involved, those can be treated. That's not a vascular etiology, and carpal tunnel syndrome related to deposition of dialysis amyloidosis. So in summary, hand pain can be due to reasons other than distal ischemia. So not every hand pain is related to Steele syndrome. Complete imaging of the arterial tree should be performed if arterial stenosis is detected. On other routine imaging, especially with ultrasound of peripheral arteries. Delay in recognizing a true Steele syndrome or true arterial stenosis can lead to irreversible tissue damage. Alternate etiological factors include involvement of peripheral arteries and peripheral nerves and musculoskeletal system, and controlling systemic factors can potentially reduce the incidence of distal hypoperfusion in high-risk patients, especially diabetics, elderlies, and patients with multiple AV accesses on the same side. Thank you very much for your attention.